The chair and moderator is Simon Bland, CEO of Glide. Speaker number 1 will be Dr. Moses Laman, Deputy Director, Science and Research at PNG Institute of Medical Research. Dr. Laman has over the last 12 years, he has led multiple field-based, health-based, facility-based studies on malaria and other diseases of public health importance in developing countries. Moses collaborates widely with many international research groups, and in his in-depth understanding of the Melanesian culture, values, perspectives, and relationships continues to be instrumental to the success of these studies. Mr. Bobogare is the Director for the National Vector-Borne Disease Control Program in Solomon Islands. He entered the Solomon Islands Public Service in January 1989 and has as a malaria parasitology officer. He became director in 2009, after which most partners, including RAM, USAID, World Bank, and SPC, completed their direct support to the program, leaving GF, sorry, I'll just kind of skip that. He served under 4 directors during his service from the anti-malaria program. Speaker number 3 is Dr. Corine Karema, Director of Malaria and NTD's Global Health Quality Equity Health Centre, and former Director of the Rwanda National Malaria Control Program. And speaker number 4 is Ms. Juliana do Rosario, Regional Malaria Officer, Timor-Leste. Thank you. Because we're running late, I will pass on to the moderator. Thank you.
That's a good start. Maybe it's working now. Good afternoon, everybody. Thank you so much. So this is a session entitled Integrated Approaches to Disease Elimination in Asia Pacific and Beyond. And we really wanted to examine how integration efforts are implemented and adapted to the country context, and most importantly, to share some of the experiences. And we have this wonderful panel with us, but we also have a wonderful audience with loads of experiences and perspectives, I suspect, on approaches to integration. And there's no such thing as a free lunch, so I'm hoping there'll be a little bit of time and we can get your perspectives and your questions. And I've already singled out a couple of people who I might ask questions of if we've got time. Look, we've heard a lot about issues of integration so far during this meeting. We started off with Christoph's panel on innovative finance and finance for innovations, and we had a conversation around it's not innovation for the sake of innovation. And similarly with integration, it's not integration for the sake of integration. Helen talked about being sort of consumed by process and forgetting impact, and it's got to have an impact so that it's measurable and demonstrable, I think, to be effective. I also can recall conversations I've had in the past about issues that have been mainstreamed. And mainstream sometimes is a synonym for ignored. And I think the same is true of integration. We don't want integration to mean ignored. And Dr. Champa's presentation earlier today gave a few cautionary words about forgotten diseases, moving beyond elimination and then just forgetting about it, not giving it the attention. So it's integrated, but that basically means we're not putting any focus and attention and resources into ensuring that the job is sustainable. I was also reminded, talking to some Wontoks from East Sepik and West Sepik earlier today, integration is not a new conversation. It's been around for decades, if not centuries. When I lived in West Sepik, we had the West Sepik Integrated Rural Development Project. There was a huge East Sepik Integrated Rural Development Project because the understanding of the interconnections between health and education and infrastructure and water and sanitation and incomes and rural livelihoods, was clear. And indeed, the adoption of the Sustainable Development Goals, moving beyond those MDGs, recognizes those interlinkages. So the theory is there, but the practice is a little more difficult. Two big influences in global health that we think about are, of course, the Global Fund and Gavi and these big global health initiatives. Domestic resources are still by far the most, and community direction and government direction is by far the most important and prominent factor of health service delivery. But these big global health institutions play an important role of creating incentives. And it's really good to hear that despite that old work, Helen, that you talked about, I think it was the Health Systems Funding Platform, if I remember the acronym right, oh boy, it was a process gone crazy, and when we did give up. And those health institutes are donors, but also implementers trying to answer lots and lots of different calls and different perspectives. So a really difficult situation. But I am very hopeful, to use Christoph's language, very hopeful that the world is different today. And seeing the Global Fund and Gavi think about replenishing in the same year, thinking about common investment cases, the malaria vaccines that make it Gavi's business and the Global Fund's vaccine business. So some drivers there that are pulling some of these GHIs closer together that I think is really important. I think one thing that I'd like you all to think about, and I hope we'll think about as we talk about disease elimination and integrated approaches to disease elimination, are the incentives. What are the incentives that would encourage integration? What are the incentives that encourage integration for success? But what might some disincentives be, creating sort of perverse outcomes by having sort of incentives that really skew decision-making in directions that are integration for the sake of integration rather than for the results we want to achieve. So I hope that just gives a little bit of context. I'm Simon Bland. I work for the Global Institute for Disease Elimination, a very small and young institute based in Abu Dhabi through philanthropic funding from Sheikh Mohammed bin Zayed, the president of the UAE, and a little bit of money from the Bill and Melinda Gates Foundation. And our role is to really sort of stimulate operational research, advance knowledge, and try and find ways of accelerating progress towards disease elimination, and using the knowledge that we help generate and the knowledge that we gain from others as part of our advocacy for the arguments of disease elimination. So let me begin with Moses at PNG IMR. Moses, we're in this incredible country, beautiful country, really diverse country. I mean, I don't think I've lived in many. I don't think I've seen this diversity anywhere, and linguistically and culturally and topographically, and I don't know, I guess it's probably 90% plus rural, and we saw pictures earlier that Stefan was showing of, we have to use helicopters to deliver services and commodities. So, I was looking at prices to fly to Vanimo last night. I nearly fell off my chair. I mean, the prices, so the cost of doing business in this country is really expensive. But with all those challenges and the context, Moses, from your perspective, what are some of the opportunities and challenges that you see in this context towards sort of more integrated strategies towards the elimination of malaria and more broadly, disease elimination? Thanks.
Thank you, Simon, and thank you, everyone in the audience, our distinguished guests, and welcome to Papua New Guinea. If you talk to the provincial health authorities, many of them are here, and in Papua New Guinea, the provincial health authorities deliver health services. It's a decentralized health system where they are the key. They actually deliver health services in our country, and we acknowledge the 13 PHAs who are here with us. They're really important to the delivery of health services in Papua New Guinea. And if you talk to them, almost all of them talk about integration. And that's their preferred way of working. They want health services to be integrated because in Papua New Guinea, there are so many challenges, and I don't want to repeat them. We had all of them over the last 1.5 days already. But some of them are worth mentioning again because they are huge. Look at the health workforce shortage in this country. For a population of about 12 million people, minimum we would need in terms of all cadre of health workers is about 80,000, but currently there are about only 17,000 only in the health workforce. And for them, integration makes sense, and it's the way to go. But like you rightfully said, not everything should be integrated. But when you talk to, for example, we talk about this a lot with many of the provincial health authorities, and for them, it's much more cost-effective and efficient if they are able to integrate health services because of those realities about the shortage of health workforce, deteriorating health infrastructures. And these deteriorating health infrastructures have not been stabilized. This has been neglected for the last 49 years. I can say that as a Papua New Guinean, with concern for the health sector in the country. And those deterioration over the last 49 years are felt by those people who deliver health services in this country. And it's a very serious issue when we look at how do we improve, say, malaria, for example, diagnosis and treatment in this country. And not many, the current malaria tools that we have now, they are performing well. We don't have artemisinin resistance in this country. We already had this entomology team talk about, we don't have pyrethrid resistance for all the insecticide resistance monitoring that the PNGIM has been conducting all these years. Artemisinin resistance, that the National Department of Health has been doing those therapeutic efficacy studies, then we have been supporting them. We don't have those, and those are actually, these are opportunities. I want to talk about the opportunities first. We don't just, in 2009, the country changed the first-line standard treatment guidelines for malaria from chloroquine and fencidar to artemether lumefantrine, and for Vivex malaria plus primaquine as well. And we don't have drugs that we have parasites that are resistant to now, like chloroquine that we just used recently. Now we have drugs that are performing well. We talked about diagnostics that was not available for most of the country. Dr. Binga talked about clinical diagnosis of malaria just 10 years ago when he was a practicing clinician. Now you have diagnostics that are available right to the aid post in the rural areas. And this is an opportunity that we can now diagnose and treat malaria within 20 minutes. And those are opportunities there. These are not just challenges. And so the current diagnostic tools we have, the current treatment we have, of course we had the bad news about the LLI and bioefficacy and all the challenges, but we never used to even have insecticide-treated badness prior to 2000. But those are tools that we have now. We still have challenges, of course. And you look at Vivex malaria. We have 30% of the burden of malaria in Papua New Guinea is due to Vivex malaria. But there are better RDTs becoming available. And this morning we just spoke with Dr. Morawaya from Millen Bay, who identified the problem of mixed infections, for example. Everyone is called mixed infection. We need better diagnosis for things like Vivex malaria. And that's true. So those are things that you could optimize. Those are adjunctive things that you could still improve on. And now better diagnostics for Vivex malaria are soon going to become available. G6PD deficiency, for example, and we cannot adequately treat patients with Vivex malaria because our current first-line drugs, they get artemether lumefantrine, they get better, but then they don't take primaquine because it's 14-day, and the current regimen is 0.25 mg per kilogram, which is a consecutive, very low dose. We need to shorten the regimen to 7 days and increase those so we optimize treatment of Vivex. Those are work that we have been doing for the last couple of years, and those will be changing treatment guidelines soon. So not everything is bad. There are some opportunities with the current tools that we already have. But there's still room for a lot more improvement, and it comes down in the end to our health systems, making sure access is there and the drugs and the RTs get to health facilities that are supposed to be receiving them. Functionality of those health facilities that are closed, how do we get them up and running again? The hard-to-reach populations, we are not able to reach them because of the limited workforce and so forth. And so integration becomes really important. And even though it might be challenging for diseases like malaria, for other vector-borne diseases like lymphatic filariasis, they can benefit a lot from the strength of programs like the malaria program. Because, for example, lymphatic filariasis is a much, in the PNG context, maybe a much more easier vector-borne disease to eliminate, for example, because the parasite is much more bigger, transmission is not so good and not so efficient like malaria, because in Papua New Guinea, the vectors are inefficient compared to other settings, and the mass drug administrations that we have trialed and has become part of the standard treatment and now expanded by the National Department of Health under Lucy Jones' lead to include the 4-drug therapy to go on and become vital tools for other entities. Those are great opportunities that most of the provincial health authorities always advocate for integration. So from my opinion, I think it's not a hard sell for Papua New Guinea. Many of the provincial health authorities, they like integration because it adds value to their work.
Thanks, Moses. It's helped. I mean, liking it is one thing, doing it is another. I have a follow-up for you. So you started to talk a little bit about the strength of malaria surveillance, malaria programming, and lymphatic filariasis. So maybe you could talk just a little bit about how you might leverage some of the landscape work you've done, how you might leverage some of that strength in malaria surveillance for a better understanding of lymphatic filariasis epidemiology and endemicity across the country.
Thank you. So when you look at some of the data that the malaria program generates, it's huge for this country. But they might be disconnected, like some of our presenters in the morning said. But that data is already there. But you look at other vector-borne diseases, that data is non-existent. And so that's where integration would really help for other vector-borne diseases. Because, say, lymphatic filariasis, for example, the vectors are the same. They transmit them in settings like Papua New Guinea. And so where there is malaria burden in hard-to-reach populations, you're likely to have other vector-borne diseases as well, like lymphatic filariasis. And so that's where integration comes in terms of the malaria data support. And that's what's already happening under research conditions, where the Rotarians against malaria have a lot of data in terms of bed net distribution or burden of disease, or the health workers upload data into the ENHIS system that tells you where there are outbreaks happening. And those are data that can help to inform other vector-borne disease programs like lymphatic filariasis to support generate that type of data and enable us to treat conditions that might not be fatal like malaria, but they have severe comorbidities and stigma that cripple people who have those conditions in most hard-to-reach populations in our setting.
Great, Moses. Thanks so much. We'll come back, but let me move on to Albi, if I may. So Albi, in the Solomon Islands, well, we heard about that pivotal year of 2015, and we saw sort of resurgence and increasing incidence of disease. So in 2021, the government of the Solomon Islands formally launched the National Healthy Settings Policy, focusing on this idea of healthy villages. So really, could you talk a little bit about that policy, the goal of that policy, and how it might be leveraged or used to support the targets of malaria elimination and strengthening the health system more broadly? Try this one, Albie, see if that works.
Oh, no, it's working. Yeah. Good afternoon, everyone, and thank you, Simon. So, yeah, what I will share with you is one of the policies that our ministry developed in terms of supporting the integration to support provinces with the programs that exist within the health services to work closely with communities to achieve better understanding and engagement to achieve what plans that are feasible to eliminate or reduce diseases that are of interest to their communities. So in 2021, the government, through the ministry, have approved a policy called the Solomon Islands National Healthy Settings Policy. And this is a policy that adapts sort of a holistic effort towards promoting and preventing health issues such as malaria, communicable diseases, water, sanitation, and hygiene, and nutrition. So it focuses on the idea of a healthy village, which brings together individuals, families, communities, and the health programs who are mandated to support these communities. They work with the national and provincial health centers and community. It is like a multi-sectoral policy and engage stakeholders and partners from key government ministries, donor agencies, faith-based organizations, and also non-government organizations. So this policy actually started off in the, since 2015 also. So it's piloted in 2 provinces. And the ministry to its, the ministry have what we call the health promotion department. They are, mandated to lead this going forward and roll out the policy to other provinces. The ministry also, together with other ministries and programs, including ours, the National Vector-Borne Disease Control Program. So the launch of this policy is, to us, is like a critical step towards targeted planning and implementation of health activities at the community level. So we use this policy as an opportunity to engage with the whole, like the whole level, different levels of communities, to answer or to answer some of the what we call challenges that the ministry or the programs have been facing, and having the communities or the people that we serve just looking at us. So, with support from the national and provincial health authorities, the formulation of the targeted plans, we take into account the incidence, the prevalence of diseases, for example, malaria, diarrhea, all these kind of diseases that are affecting the communities. And of course, other social and geographical considerations. So it has resulted in the establishment of village health communities. So they form their own communities, and these committees, they also make their own plans. that they think it's feasible for them to achieve as their health, the priority in the health programs. So these communities were also leveraged to support Solomon Islands malaria responses, where the provincial teams, the health teams, identified, local groups to develop their micro plans and to respond towards the high malaria burden zones or areas. So the these village communities work in close coordination and also collaboration with local area health centers and also provincial health authorities, including effective resource mobilization and development of a suitable model for their community. It's not so easy for them because sometimes in their plan they would come up with something that the program cannot support. I mean, it does not have the resources to support, so we have to source other areas with other support organizations, or even their members of parliament or their constituency or their wards, to help them, support them to achieve what they want to do. If they see, okay, we need to focus on what supply. I mean, the malaria program cannot supply that, so that we have to seek other sources to help support them to achieve their plan. Yeah, so specifically to malaria at the community level, the activities include awareness about the disease and the community participation in malaria service delivery, such as reduction of malaria breeding sites, distribution and proper use of bed nets, adherence to drug regimens, and empowerment of community leaders with malaria guidelines. So, despite of this, success of having this policy, of course, as Simon mentioned, there are challenges which will require more opportunistic ideas. But we have encountered in scaling up the policy since launched in 2021. This has slowed down its adaptation to other provinces. One significant challenge to fully realize this policy is the lack of allocation of adequate resources. This includes lack of course, funding for implementation of the community plans, as I mentioned. Community requires, if you ask them to fill up breeding sites or drain out breeding sites, they will need, simple tools, handhold tools. And so those kind of things that they will demand to support them. So funding also in terms of monitoring and evaluation of their activities, especially in mobilizing, moving around through the different levels of the health service. So shortfalls are being faced in terms of human resources as well, lack of data and administration staff, coordination at national and provincial levels. It is key to note that these are similar challenges that hinder the strengthening of overall health systems. That these and could impact the overall health profile of each country. So they could be mitigated by clearly defining the roles and responsibility of national and provincial stakeholders, by ensuring timely adaptation of health system reforms under the Ministry of Health. So to ensure sustainable fiscal support, the role of village health committees can be expanded to explore resource mobilization efforts by leveraging provincial and village resources, including the budgeted plans. So I think that's what I want to share, but and I also want to thank you to Apolma and the PNG people for having us attend this summit. Thank you, Simon.
Thanks, Albi. It's really interesting, and I've heard several mentions to healthy islands here, and so when we turn to the audience, maybe we can have a bit of a conversation around that. So you're piloting this in 2 provinces, is that right? How many villages? Do you know? 15 villages. And so I guess the question for me is, what does success look like? How do you evaluate that and make some determination about then moving beyond pilots to more villages and more provinces? Microphone, Albie.
Yeah, so as I mentioned, the focal point to drive this policy at the ministry level is the health promotion team. And so, like for our other programs, we join them and support them in whatever ways, even physically or providing some other resources to get the teams to travel and go to the communities. We have worked with Rotarians Against Malaria from Australia. They provide the tools that we provide to the communities when we reach out to them. Yes, so these 2 pilot communities, not communities, but provinces, they selected 15 communities that they worked with. So the monitoring is before they go to work with these communities. They analyze the whole province's data, but for this, in this case, is for malaria, and they identified what's the current situation in those communities, and then they monitor after they worked with the communities. And so, yes, it actually removed the cases from these communities after, for the duration of the work that they did. The other thing that we saw is we need to have regular communication with these communities, even after the work with them is stopped. So we cannot just leave them. So the health teams must always try to communicate with them and find out what's their status and how they can help or what they need, this kind of thing. That continuous support needs to happen. Yeah.
Great, thanks so much, Albi. And maybe we'll have a little bit of a conversation about the community. And Sartak and I were talking earlier about sort of villages and units of development and where impact is felt, where integration is perhaps the most sensible and easiest. So it's great to learn lessons from that sort of healthy village and healthy islands approach. Corine, let's turn to Africa. It's great to see you here. I think it's the first time we've seen each other in this part of the world. Corine, you've got a wealth of experience across Africa, across malaria and NTDs. I'd really like to sort of hear from you some of the last mile disease integration lessons that you can share from Africa.
Thank you very much, Simon. First of all, I would like to extend my heartfelt gratitude to the government of PNG for hosting this pivotal Asian malaria Pacific Malaria Leaders Summit, and I will also my sincere appreciation to the Minister of Health for inviting us to also share and give us an opportunity to convene and address the critical issue of malaria and NTD. And I want also to commend AFLMA for the exemplary work, and to everyone, congratulations for this summit. I'm learning a lot. I was telling Lady Rose that it took me 3 days to come here, but I am pleased with the exceptional content and the insight that I'm going to gain. So Simon, in response to your question, so allowed me to shed a light on the progress made in Africa. Of course, we don't have many countries that have eliminated malaria and NTDs, but we have great examples that I think that sharing the experiences, we also help colleagues from the region. So, for instance, recently we had a certification of the Cabo Verde as a malaria-free country, and this really underscored the strong political commitment and leadership. Before I came, I was attending and teaching at the course of malaria elimination and eradication organized by GLAD. So this is a course which is African-led and implemented by African universities. So this year it's the University of Global Health Equity in Rwanda and Nagushi Institute in Ghana. And so you have senior leadership manager of different African national malaria and NTD program that of course are getting some leadership and management skills, but they also get the experience of sharing their field experience as well as the implementation. And what is really good is Capo Verde team was there. So I was telling them, why did you invite me, since the people who are doing the great job are there? And really the Capo Verde team, they really emphasize the leadership and commitment, strong leadership, strong political commitment. And and then for them, they say that they were able to eliminate malaria thanks to the leadership of the Prime Minister. So the Prime Minister was leading an interministerial committee that was really following malaria intervention, looking at surveillance, and then also giving ideas on all the decision, especially in politics. And this is the case also, I can give the example of Togo. Togo is the first country that has eliminated 4 neglected tropical diseases, and it's same. They're also mentioning strong political commitment and leadership. So this is number one. The number 2 is integration of service delivery. And, you know, talking about integration, it's not only within the health system, but it's also at policy level. So for instance, I can give the example of Rwanda. In 2008, the government decided to integrate the malaria and NTD national program, which I was the first director. And this helped us not only to facilitate efficient utilization of resources, but also having impact. So for instance, integrating the NTD indicators, because before they were a vertical surveillance system, so they were integrated, and this really helped us to also track, monitor the disease. And we also saw that, for instance, in Togo. In Togo, they also established the LF surveillance system. They were the first one, and then integrated also within the community. So we have also many examples, like in Rwanda and others, where community health workers are delivering a component of a package of intervention, treating malaria, pneumonia, diarrhea, and then also doing sensitization and mobilization of disease. And we are seeing that there is really impact in terms of increase of coverage of the health-seeking behavior of the community. Children are treated on time, proper treatment, as well as utilization of all the malaria intervention. So I think it's really important to have this integration both at policy level, but also at delivery level. The third one I've touched on is surveillance. So the fact that NTDs as well as malaria surveillance system are integrated and can be monitored within the health information system up to the community level. And the last one, I think it's the partnership, collaboration. We have seen that at the beginning it was really difficult, but we have seen, for instance, with the global funds, they are flexible. The flexibility of partners to even support beyond the scope of their diseases. So, for instance, in Rwanda, the Global Fund has helped to strengthen the health system, to also support beyond malaria, so support the training of community health workers to deliver pneumonia, antibiotics, as well as zinc. So this is really very important. And then we have seen also in Capo Verde flexibility, agility, so using surveillance to tailor and their intervention. So I think for me, those are the lessons that we can share from Africa. Thank you.
That's wonderful. Thanks so much. Thanks, Corine, so much. I'm going to come back to that partner flexibility point when we open it up for discussion, because I think that's really important. And I think that's a bit of a sea change that we're seeing that is going to be really quite important for us. It's fabulous to celebrate Cabo Verde's success, but it's the third time it's eliminated malaria, right? So post-elimination surveillance, Dr. Champa's message, does it then become a forgotten disease? Do we not care anymore? What are your experience on surveillance? I mean, you don't have a lot of countries that are in that post-elimination phase. You've got Mauritius, you've got Cabo Verde, but just talk a little bit more about the surveillance system.
Yeah, so if we take the example of Algeria, we take the example of Mauritius, which was certified free for malaria, actually when I was born. This is 50 years. So, yeah, I'm 50. So it's maintaining, first of all, it's sustained funding. I think it's critical to keep funding surveillance system, to keep tracking, as well as the cross-border collaboration. I think those are really key elements that help countries to sustain. But surveillance, tracking, it's really very, very important.
Thanks, Corine. Thanks very much. It's if a system is largely dependent on development assistance for health external, I'd suggest that surveillance is not a terribly attractive investment for many of those donors, and that's been a big gap and a big challenge, and we might think a little bit about that. We'll come back onto cross borders in a minute. Thanks, Corine. Let's move to Juliana. Salamat siang. Nice to see you, Juliana. You're in a position of success. Okay, so Timor-Leste has done a really good job. It's on the cusp of having its documentation finished for being malaria-free. It would be great to just hear a little bit from you about the experiences and how you've approached that and the lessons that you've learned in your road to the elimination of malaria in Timor-Leste.
Yeah, thank you very much, Mr. Simon. I'm so glad to be here. To share our experience so far. Actually, last 15 years ago, Timor-Leste also considered as a malaria endemic area. But since coming soon on 2015-16, our cases are going down. And now, starting from 2020, we reported RAS, indigenous malaria cases. So based on WHO guideline, we are proceed to the malaria-free certification. Just get the key point here is the how to sustain is integration. So when you are talking about the integration, there are some points that need to be thinking of. As we know, that Timor-Leste is a border with Indonesia. So in our context, we have done so many, not so many, but we have done some progress that to maintain our sustainability on malaria-free status. One example is, as mentioned by our Honorable Minister, that the implementation of the malaria activity has been integrated with the primary health service delivery. It's also covered in border area. Timor-Leste has 3 municipalities which is considered as a high border area, which is located with border with Indonesia. So in these 3 municipalities, we conduct this parasitological surveillance and include this factor control surveillance, which is implement regularly. The second practice that we have done is it's also based on the recommendation by external review, which has done in 2020, that establishment of integrated vector-borne disease. So now we have the strategy in place. So we are trying to proceed to the implementation of integrated vector-borne disease department in our country. So it will include malaria and other disease which is transmitted by vector. And this, the second one is, when we are talking about the sustainability, one issue is big challenges in Timor-Leste is human resource. Just for your information, that when this national malaria program established on 2005, all of us are temporary staff, and all are covered by Global Fund budget. Only there are 2 persons, one program manager and another person is a vector control officer. But the great thing is just 2 years ago, all of us, including me, was absorbed to the health system. Yeah. Even though still temporary, but it's all covered by health system. Apart from this sustainability of human resource, just in last year, under lead by Director of Human Resource, Minister of Health, and collaborating with the Minister of Administration State, we have done some functional analysis to do this micro plan, how to absorb all the human resource into one system to guarantee that implementation of malaria activity is in place. And the most important thing is collaboration with Indonesia. I think just recently we have done meeting with the Indonesia part, which is it's bringing a good result that we agree to do a framework, which is it include all activity that need to be done in that border area. So it's coming from Timor-Leste side and also from Indonesia side. So the simple thing that we have done so far is we are trying to share our data to each other by WhatsApp group. So we know what is the situation ongoing in each part. From our side so far, we are fully implementation on surveillance, parasitological surveillance, and also vector control surveillance. So we hopefully next coming cross-border meeting will be reaching a good integration activity to prevent malaria disease in the border area. I think that's all.
Thank you, Juliana. I think that's fabulous news that you had external support, global fund, you had temporary staff, and it was seen important to absorb those staff into the health system. Do you have any insights of how that decision happened or why that happened? I guess that's a ministerial cabinet decision, but it's a remarkable success story, actually, of external support, building capability and capacity, and that being absolutely absorbed and owned by the system itself.
Yeah, I think this from the view of this thing, we have a very good, strong commitment in this issue. So it's led by our honorable minister yesterday that just thinking that the importance how to sustain the implementation. So our minister has taken over all the decision to cover all the human resource to proceed to the health system so far.
Brilliant, Juliana, thanks. And, we heard about the importance of leadership from you, Corine, as well, and the creation of these malaria and NTD sort of programs and units. And Tim and I were talking earlier about leadership and how much leadership makes a difference, not only at the national policy level, but also very much at the local delivery level. So thank you all for those. We've got 10 minutes left. I really just wanted to open it up now to you all, if you have any questions for the panelists, if you have any comments or perspectives, just to get those out. And then I'd like to have a little bit of a conversation about partner flexibility and incentives. So let me open up to the floor to see if there are any questions for the panelists. Yes, please.
Thank you so much. This is it's very good discussion. I'm Srihari Acharya. I work in the Greater Makang sub-region working for the CSO platform. And this is very relevant discussion to the region where I'm working. So my question to any panelists, I think I heard some encouraging initiative from Rwanda and the Timor-Leste in terms of integration. When we start designing integration, we look from the national priority of the disease, but when you go down to the community has different priorities. Sometimes it doesn't align. So I'm more interested to hear how you balance these two priorities.
That's a great question. Thank you. Let's who'd like to have a go at that one? So balancing the perspectives and priorities at a national level where they may not be totally aligned with different communities because they have different perspectives and different priorities.
Thank you very much. I'm trying to express what is going on in Timor-Leste. That so far we give a priority based on this stratification that which diseases is contributing most issue in our country. So malaria, following by TB or other diseases, still contributing this high burden to us. So when I look back in the past, it's the data showing that most of the Timorese people are suffering for this kind of disease. So thinking of this our minister and our government are thinking to give a priority on those activity which is presented by Minister of Health or by program as well.
Okay, thanks. I mean, I think it's a tough challenge. I think you will have national priorities that will be set through national processes. How far they are informed by the collective communities and their priorities, I think, is really interesting. I've been working on polio eradication and talking to communities in Pakistan about interventions there, and the interventions for polio are not interventions that they care about anymore. They haven't seen this. They don't want this. They want other things, and so the guidance and approach there is, well, figure out what they need and bundle and package what you're trying to deliver in with the things that they need. So, but those community perspectives are going to be hugely important, because if there is a misalignment with national priorities, then the likelihood of adoption and sustaining programs, I think, is very limited. Please raise hands if you have comments or perspectives, but that takes me to think a little bit about that issue of healthy villages and healthy islands that I think I've heard about here. So I think it was Brendan yesterday talking about geography. The closer you are to the equator, the more difficult it gets. And geography plays quite a role in the endemicity and the ability to really address malaria and other infectious diseases. So if you look at Papua New Guinea, there will be some places that are easier than others. And I was talking to folks from Indonesia yesterday, thinking about the provinces in Papua, and going district by district. A couple of districts now eliminated. So just thinking about PNG, and Moses, maybe you can answer this. Tim, maybe you and others. But are there areas where a focus would say, so we have an increasing number of provinces that are malaria-free. So I think about island provinces, Manus, for example. Would that be possible? I think Tim was talking about a place in Bougainville, South Bougainville. But is that an approach? Because as we talked about the Healthy Villages approach, going and proving what is possible, sort of in communities, is it similarly possible to say, or to demonstrate what is possible at a provincial level? Some will be easier than others, but at least it starts to show progress that is desperately needed. Moses, what do you think?
Yeah, thank you, Simon. That was an important discussion that came up in the malaria strategic planning meeting that late Leo Makita led with all our partners in country. Whether to look at it as, but because of the very high endemicity of malaria in Papua New Guinea, this did not take prominence. But if you look at some of the work that has been ongoing, there are certain areas in Papua New Guinea, for example, Kandap in Enga that is above 2,000 meters above sea level, and others like Eastern Islands that is about 1,600 meters above sea level. Obviously, high altitude settings don't have transmission of malaria, but there's a lot of people moving to the coast and moving back up that are having malaria. And then even in the island setting where you don't have malaria, you get sporadic outbreaks here and there. Like last year, there was one in Karamui, in lowland Chimbu. And so this did not prominent significantly, but it did inform how the national program decides to distribute bed nets, also to find a cost-effective balance. For example, the program decides to give bed nets in settings lower than 1,200 meters. So it does influence decision-making, and cost is an important part of it, to find cost-effective ways of doing that. And stratification has been an ongoing important discussion that the teams have been working on, generating data to assist. And there are some provinces like North Province, sorry, the autonomous region of Bougainville, that has a very low burden of malaria compared to other settings, and the healthy island concept has been coming up as an important intervention. And so it's diverse, but because of the very high burden of malaria in Papua New Guinea and like we discussed yesterday, the northern coast, the Pacific provinces, Madang, Morobe, the New Guinea Islands, and of course the eastern tip, Milne Bay, those are very high burden settings still. And so those discussions have been coming up in the National Malaria Control Program, but the burden is still too high to talk about this in detail.
Got it. Thanks, Moses. In the final couple of minutes, I just, if I may, Lady Ros, come to, oh, hang on, I think Glenn has a, please, go ahead.
Something we haven't talked about at all, and we're going to finish this meeting this afternoon and not talk about it, and that is the alignment between, you mentioned alignment between national and the community, but one bit of alignment that is perhaps hidden is the community's view of disease. And we're all assuming as scientists, etc., that everyone believes that malaria is caused by a parasite carried by mosquitoes, and TB is caused by a bacterium that's sprayed out by respiratory droplets. And most people in villages do not. Most people in villages believe that especially chronic disease or recurrent disease is caused by sorcery. We call it sanguma. And it's a particularly nasty society detriment, we'd have to say, in PNG. It can lead to torturing and murdering of innocent, usually women, who are vulnerable because they haven't got family to support them, like widows and divorcees and older women. And it's something we really need to deal with in our community from so many points of view, not just from disease, health-seeking behavior point of view. And so I've seen that a small thing like just the ability to diagnose malaria in the community is having a really good effect. That when we have these community malaria volunteers with the capacity to see a lineup of people on the veranda of their house every morning who have got a fever and not feeling too well, and they can see this person prick the finger, analyze the blood, they watch the reaction in the RDT cassette, and then those with malaria come up positive, and they're shown how it comes up positive. And those who are negative usually have respiratory symptoms, so they've got a common cold or something, or some kind of viral infection. It's a really great way of educating the community about disease, and I can see this as being an important way of reducing this belief in sorcery and sanguma as the cause of disease, not just for malaria, but like HIV and TB and many other chronic diseases.
Thanks so much, guys. It's an important point. Actually, there was a documentary I saw last night about sanguma and TB. I think it was in Western Province, but exactly the same. The same. Last couple of minutes, Lady Ros, if I may. We had a couple of comments about. Corine was talking about Global Fund flexibility. Juliana was talking about Global Fund supported posts being absorbed within the health system. I was at a meeting in Nagasaki last year where someone said to me, "Oh, the Global Fund's going to do neglected tropical diseases now," and I went, "Really? Well, it wasn't like that when I was on the board, so I wonder what's changed." I think what they were saying was that there is a willingness and a recognition to have Global Fund resources be used in ways that are context-specific, context-relevant, driven by what countries are looking for, staying true to the mandate of the 3 diseases and health systems. But I wondered if you could just talk a little bit about, from your perspective as the chair of that board, of the Global Fund's willingness to be supporting systemic change, sustainable sort of development, and using the entry point of the 3 diseases to actually, if you like, try and raise all boats. Thanks, Ros.
Thanks very much, Simon. I don't think it's a new thing. All along, the way the Global Fund was constructed was absolutely to do what countries wanted them to do. It is a country-led model. Countries, through the CCMs, put the funding request to the Global Fund. Yes, historically we only funded programs in HIV, TB, malaria, and health system strengthening. But they can be pretty broadly interpreted. Now, in fact, very broadly interpreted. There's a lot of flexibility. But it does come back to what the country asks for. So I would encourage countries to think more broadly about what they want to put into their funding requests. In the case of Rwanda, where we have supported a lot of health systems work, but this is because that's what the government wanted the Global Fund to fund. I think there's enormous opportunity for further integration of services using Global Fund money, but the health departments, the CCMs, the provincial health authorities in countries where health services are decentralized, have to think through what is it in the way they're delivering their services that can easily be funded under that model. There's huge scope. And not just through the traditional country programs. We have a whole line of funding called catalytic funding. And in West Africa, for example, we've currently got a very big program of training community health workers. The seed funding for that came from Johnson & Johnson, with Global Fund as well. But then Gates Foundation put matching funds. So it's a huge program now that can be earmarked, like Dr. Rogers was talking about yesterday, but not just for HIV, TB, and malaria. These are community health workers, as in Rwanda. In Ethiopia, we funded, when Tedros was the health minister, it was his conception, a huge program of community health workers. So there is enormous scope and flexibility, but countries need to think through what they want to put in their funding request and negotiate around that.
Thanks, Ross. It's a great message. And let's have country coordinating mechanisms that recognize that and respond to that and give you articulate country demand. With that, I want to just thank the panelists for joining me for this afternoon, for you, for sharing lunch with us. And once again, please join me in thanking the panelists.